session is on real-life challenges in vasculitis. And as we know that recent research into the pathogenesis of large vessel vasculitis has led to development of newer therapies which target the cytokines and the various cellular effectors of inflammation. Parallelly, there is a lot of research is going on the imaging field, and with the various advances in the PET scan, CT scan, MRI and angiography, we may be able to track the vessel inflammation longitudinally. There are also radio tracers which can assess the macrophage activation and immune checkpoint activity. So to address this, we have first lecture on advances in the imaging of large vessel vasculitis, and our second lecture will be on approach to DADA2 and VEXAS syndrome. As we all know, the year 2022 marks the 25th year of the discovery of the first gene, which was the MEFP gene, which was responsible for the familial Mediterranean fever. And now we have a lot of autoinflammatory syndromes, and recently the DADA2 and VEXAS, which are new kid in the block of the autoinflammatory syndromes. And it should be our proud that the DADA2 Foundation held its international conference, and in 2020 for the plenary session, Dr. Aman Sharma sir was given the lecture on the DADA2, and we are privileged here to listen him in the approach of the DADA2 and VEXAS. So to chair this session, I would like to invite Dr. S. Rajeshwari ma'am and Mamta Venkatesh ma'am, and we'll start the session. Thank you.
The speaker slide, first speaker slide.
Good morning. So today, advances in imaging of large vessel vasculitis. We have Dr. Sumantrao Mondal, who's an assistant professor at Department of Clinical Immunology and Rheumatology at Kolkata.
Good morning, respected chairperson, my respected teachers and my colleagues. Thank you, Ida, for giving me the opportunity to speak on this topic, that is advances in imaging of large vessel vasculitis. And as we all know, like all other rheumatological diseases, imaging is also being increasingly used in this vasculitis. There are different types of vasculitis. For small vessel vasculitis, we usually do not use imaging, but for medium and mostly for the large vessel vasculitis, imaging is increasingly gaining popularity, both for diagnosis and also to monitor treatment response. In large vessel vasculitis, imaging is very essential, especially for the Takayashu, because the biopsy material is rarely available for Takayashu. It needs much more expertise than GCA. And for both of these diseases, there is no specific laboratory marker or biomarker as seen in small vessel vasculitis or unclassified vasculitis. So we have alternate modalities, that is imaging. And among imaging, ultrasonogram, CT scan with angiogram, MRI angiogram, and molecular imaging like PET or hybrid imaging like PET-CT are commonly used for this purpose. So, I shall discuss this topic on two main headings: the strengths and limitations of different imaging modalities which we currently use for diagnosis and monitoring treatment response in LVV, which are the basic concept for imaging, what are usually seen in different types of large vessel vasculitis by different imaging modalities, and the recent updates over the last few years. So I have just prepared this table to compare the different imaging modalities based on few important topics. That is the radiation hazard, which is nil for the USG and MR angiogram, highest for the PET-CT and also present for the CT angiogram. Repeatability of the imaging modality, which we may require to monitor treatment response, is most for the USG, maybe least for the PET-CT, and these two are limited by either cost or radiation hazard. Of course, the cost of the imaging modality, the lowest one is the USG and the highest one is the PET-CT. The scoring system to quantify the disease burden is present for USG and PET-CT, but not for the MR or CT angiogram. And the evaluation of the arterial territories is limited for USG. It cannot image the proximal portion of the ascending aorta. If you have not expertise or if you have not the proper transducer, you cannot image the arch of aorta, and either you perform a transesophageal echocardiography, you cannot image the descending thoracic aorta. For imaging of the renal artery, you need a good patient preparation and also a good deal of expertise. For MR and CT angiogram, they can evaluate almost all other arteries. PET-CT, there is controversy still now that they cannot image the cranial arteries due to the background uptake by the brain, but it may be overcome by the recent generation PET-CT scanner. This is a short overview. What we commonly see, the halo sign or compression sign, we commonly see in joint cell arteritis. For Takahashi arteritis, the counterpart is macaroni sign. By CT angiogram, we see the mural thickening, that is the thickening of the arterial wall, their enhancement after contrast uptake, the presence of stenosis or dilatation or calcification, and surrounding tissue edema. I am not going into the detail of the sensitivity and specificity of the different modalities because this is beyond the scope of this discussion. The same thing, the same features can also be assessed by MR angiogram, while MR angiogram usually gives a better spatial resolution for the soft tissues and the CT, and for the FDG tape, we can see in addition to the mural thickening, the tracer uptake. So what we commonly see, the thickening of the arterial wall and the uptake of either the contrast material or the PET tracer. So what is the current status of imaging? This is the current Euler recommendation, and if we can see for the cranial GCA, the color-coded duplex ultrasound has become the first line of investigation, followed by the MR angiography 1. PET-CT or CT angiogram are not usually recommended for the cranial arteries. For extracranial GCA, you can use anything. For Takahashi arteritis, the first line has become the MR angiogram, and the alternative imaging modalities can be used, but color-coded Doppler ultrasound may not be suitable for descending thoracic aorta. And this is the ACR recommendation, and it is clearly saying that imaging can be a decision maker when a patient is in clinical remission. If there is imaging involvement of new vascular territories, you may change treatment or alter the immunosuppressive therapy. For GCA, the ACR has still recommended that a TAP or temporal artery biopsy as the gold standard if it is inconclusive and in presence of strong clinical suspicion, a non-invasive vascular imaging can be done. So coming first to the USG, which may be the most promising tool in future for its easy availability and repeatability. So these are the common signs. This is the halo signs in the temporal arteritis or GCA. This is the macaroni sign. This is the thickened arterial wall. This one is from our institution. This is a common carotid artery with normal wall, and this is a diseased common carotid artery with a thickened wall seen in Takahashi arteritis. So it has become the imaging modality of choice for cranial GCA. The double study have clearly shown that USG almost reduced the need for temporal artery biopsy to nearly 50%. We have different cutoff values for the inframedial thickness available in our hand. These are for the common superficial artery. They are frontal parietal branches, the facial and axillary artery, which are commonly used for assessing the cranial and the extracranial GCA. We have different values in the vasculitis and their cutoff values. So these are the recent advances to measure or to get a cutoff values for the disease from normal arteries. However, there is no Indian standardization. The second concept is high resolution USG, that we commonly use a 18 MHz probe, but with a 55 MHz transducer we can clearly see the intima. and the intimal thickness show good correlation with the histological specimen, and it has a cutoff value to differentiate vasculitic from a non-vasculitic artery. Another concept is the contrast enhanced ultrasound in Takahashi arteritis. It is usually used for common carotid arteries. So after giving a contrast agent, the USG contrast agent, we can grade the enhancement of the wall, that is the presence of contrast agent in the vasa vasorum of the arterial wall, to grade 0 to grade 3. So it is a very good tool for assessing the inflammation. It shows good correlation with the ITAS score and biopsy and the FDG uptake. So in future, it can be effective for both diagnosing and detecting treatment response in Takahashi arteritis. However, it is only still used in common carotid arteries and not in other arteries. So the relationship between the vascular inflammation score and the disease activity, and this halo score, which was done based on imaging parameters of USG, and the gradation was from 0 to 4 based on the thickness of the halo. In the original halo score, common superficial, parietal and frontal of both sides along with the axillary arteries were taken with a score range of 0 to 48. And in the original study, the vascular inflammation was quantified by a halo count, that is the number of temporal or axillary arterial segment with a halo and a composite halo score. Both the halo count and halo score showed a positive correlation with systemic inflammation and CRP. More importantly, a halo count of 2 or more, or a halo score of more than 3 at least, was a good predictor of ocular ischemia. And a patient with this type of halo score had almost 1/3 of patient had ocular ischemia. And a score of more than 10 used for the firm diagnosis of GCS. From our institution, it was proposed that if we can extend the halo score by adding the subclavian artery, as this artery is more commonly involved in extracranial GCA, the extended halo score can even be better. This is the second one, the new concept, that is the GCA fast track technique, where in the same day a suspected GCA patient undergo ultrasound, and there are two techniques. One is limited, which usually takes 10 minutes, and another is extended, which usually assesses more arteries and takes 20 minutes. If we use this extended USG, there is more chance of detection of the extracranial GCA to almost 70%, whereas a limited technique can detect only for 2%. So at the cost of 10-minute time, there is a more chance of detecting extracranial GCA. Coming to the second one, the PET scan. It detects the glucose metabolism of inflamed arteries. There is increased influx of glucose in the influenced by the cytokines in different types of vasculitis. It is commonly combined with other imaging modalities like CT for both anatomical localization. But more importantly, in a patient with large vessel vasculitis, there is often non-specific features like fever, weight loss. It may detect alternative diagnosis to such conditions like tumors, lymphoma, or presence of chronic infection. One important notion was that it should be performed not better than 3 days after the initiation of glucocorticoid. So the recent advance, the scoring system, there is a PET scoring system, which is a visual scoring system graded from 0 to 3 in comparison to the liver. And in different studies, different number of arteries was evaluated. In the original study in 2018, the total score ranged from 0 to 27 based on imaging of these 9 arteries. However, in some studies, 15 or 16 arteries were included. This study showed that FDG PET scoring can differentiate large vessel vasculitis from its comparators like atherosclerosis or others. And if there is high PET scoring in the remission state, it can predict the future relapse. However, even in patients who are in clinical remission, more than 50% of patients has high PET scoring. So on the one hand, we had previous concept that after initiation of 3 days, usually there is disappearance of the PET activity, but this study clearly showed that even a patient in clinical remission, almost more than half of the patients have PET activity. This one is a recent one in Takahashi arteritis, where PET scoring was done in 16 arterial territories, and all the patients who have clinically active disease had pathological FDG uptake. And more importantly, arteries which are showing increased FDG uptake in the vascular wall, they subsequently develop new lesions like stenosis or aneurysm, etc. So the PET scoring can be used in TAP. MRI angiogram, this is the preferred one for the arthritis. We can see different types of abnormalities in different sequences like stenosis or dilatation. We can see the vascular wall edema after contrast. We can see the enhancement of the vascular wall or edema of the vascular wall. The direct contrast enhanced MRI may be useful to detect the arterial enhancement, and it may be a good tool to identify inflammation. So to detect the activity in the arterial wall, the DC MRI may be a promising tool. Last one is the CT angiogram. In active disease, it usually shows neural enhancement, and in chronic disease, that is usually calcification and lack of enhancement. I am just showing the result of the CAPI trial with Clostridium arthritis, where it has been shown that patients with CT finding of dilatation or aneurysm or occlusion had a lesser chance of new disease progression or partial progression, whereas the patient who had increased wall thickness had a greater chance of progression. So, if we get a CT image with a thickened arterial wall, there is more chance of development of new inflammation or new disease progression. It is probably the future, the PET MRI, a hybrid imaging technique. The grading can be done either no uptake to high uptake, and there are three patterns, that is inflammatory pattern, where there is PET positive and MRI positivity. A fibrous pattern, PET is negative, but abnormal MRI, that is MRI positivity, that is stenosis or wall thickening, or normal. The SUV NASH, which is detected in the PET, may be in future could be a very good quantitative measure to differentiate active disease versus remission. And in a recent study in childhood arthritis, the FDG PET MRI good information about the vessel wall inflammation. However, PET MRI is probably the future, and it may be limited by its cost and availability. And this is an image of PET MRI. This is the PET, and this is the MRI one. So imaging is a very important tool for both diagnosis and monitoring disease activity and response in LVV. The high resolution and contrast enhanced USG are promising tool, but they are only used for common carotid artery. A scoring system has been proposed by the USG and PET-CT. They may be effective for quantifying the burden of inflammation and inflammatory response to treatment, and hybrid imaging modality like PET-CT or PET-MRI in future may provide better detail about the disease activity. Thank you.
Next speaker will come.
Thank him.
Thank you, Dr. Mondal. We have the next, we'll take the questions afterwards. So we have Dr.
Aman Sharma.
Yeah, we have Dr. Aman Sharma here. Madam will introduce him.
Dr. Aman needs no introduction. My pet name previously for him was Anchor Associated Aman. Now I think I'll change the name to Dada of Vexus. So we are going to hear two talks about Vexus and Dada too. And definitely he's going to be the Dada, the good Dada. Okay? Over to you, Aman.
Thank you very much, Madam, for always introducing very generously. These are my disclosures, and none of them are in conflict with what I'm going to speak in the next 15 minutes. So I've been asked to talk about the approach to Vexus and Dada 2. I'll basically talk about when do we suspect these conditions, how do we diagnose, and how do we treat. So basically, this is a carry-home message. In an elderly male who has macrocytosis with MCV of more than 100 cytopenias, which is in contrast to many inflammatory diseases where we presume there would be thrombocytosis, venous thrombosis, MGUS, in any of these, I think we must consider Vexus syndrome. So basically, the key changer was an NEGM publication from David Beck, Peter Graysons, and Marcella Frada from the NIH, wherein it was from a phenotypic-driven to a genotypic-driven approach, where they saw all this combination of vacuoles, E enzymes, X-linked, autoinflammatory and somatic mutations, and a new entity was proposed in the October of 2020. Simultaneously, at the same time, we had a patient, I'll talk about it. We need to know that these patients can present not only to the rheumatologist because of the conditions listed here, but they can also present to the hematologists because they can have MDS phenotype, they can have megaloblastic anemia, and they can have venous thrombosis. Many of them, they have different types of skin lesions, so they can have neutrophilic dermatosis and various other skin rashes. I'll talk about them. And they can also have pulmonary manifestations and ocular manifestations. So not only they come to us, but they can very well present for the first time to the other specialities. The other thing is, the X is there in the name of Vexus, and it rhymes like Texas, as Dan Kastner always says. It can also happen in females. It can happen in females because of the reasons listed here. So there are increasing reports of Vexus also reported in the females. The clinical involvement can be there from head to toe, and all these manifestations largely are the ones that you see with the phenotypes that we identify in the various clinical conditions that I have talked about. But one thing that I will bring your attention to is there can be a periorbital edema, there can be myocarditis, and there can be other manifestations which I'll quickly touch upon in the time that I have been allotted. So the most common thing which has been associated up to 60% in the initial cohort and 36 to 60% in all major cohorts till now has been relapsing polychondritis. Part of that can be because the group was already actively working in relapsing polychondritis, but when they looked at prospectively at the RP cohort, the incidence was around 7.6%. Amongst the three clusters which were proposed by Peter Grace and Marcella Frada, the one which is associated with Vexus is type 3, which does not have airway involvement. I happened to get the chance to review this paper also before it was published, and this is an interesting publication. There is data to suggest how we can differentiate Vexus associated with RP from the RP which is not associated with Vexus. If in an elderly male with a MCV more than 100 and with a thrombocyte count of less than 2 lakhs, it has almost 100% sensitivity and 96% specificity. So between RP, if you have these things, this can help you differentiate Vexus RP from the RP which do not have Vexus syndrome. This is a cluster analysis done by the French Vexus group. They've divided this into 3 types. The cluster 1 is basically the one with the mild to moderate disease, cluster 2 which has more severe disease, which has highest mortality, and cluster 3 is low down. I'm sorry, because of the slides, kind of the formatting has changed, probably because of the software which is being used. The spectrum which was initially there was RP, PAN, GCA, but what we added to that was that we also saw a lupus phenotype. One of our Pratik on the round said that almost at the same time when this publication was, and this was shared with us, this is going to come tomorrow in NEGM, and if you have any patients, we had a patient with a SLE phenotype at the same time, wherein the sample was sent to David Beck and the NIH, and it was proven that that patient was having Vexus syndrome. Subsequently, erosive arthritis mimicking rheumatoid arthritis, HLA-B27 associated spondyloarthropathy, ANCA vasculitis type phenotype, large vessel involvement like aortitis and aortic aneurysms, and manifestation of large vessel vasculitis have also been added to the initial list which was published by the NIH group. The other manifestations are non-infectious recurrent fever and arthralgia, just like you expect from the various childhood onset autoinflammatory syndromes. This was the lupus patient that I alluded to, and I would draw your attention to look at these NCV values, 107, 104, 109, these are 112. The patient did have anemia. Whenever we used to give some steroids, there was some improvement even in the cytopenias. The only thing this person was responding to was corticosteroids. Eventually we gave IVIG also to this patient. This patient came to us from Amritsar and had various infectious problems also, which occur in many of these patients with Vexus syndrome. Various dermal manifestations can occur. There can be various types of rashes, even a livido reticularis, livido racemosa. You can have various shapes of lesions, rounded lesions. These funny looking arcuate papules I have also been associated with Vexus syndrome. We saw this in a patient of gout. Jitin Matthews, our resident, was associated. This patient presented with gout and with Vexus syndrome. When we talked to our collaborators in the NIH, they said that they've also seen a lot of gout in these patients, but it didn't come into their mind that gout can also be associated presentation of Vexus syndrome. So this is the kind of Bateman's purpura that we saw in the patient with gout and Vexus syndrome. The other dominant manifestation is lung involvement, which occurs, these publications have just come almost a couple of weeks ago. It can be parenchymal, GGOs, and even BOOP kind of manifestations, pleural effusions also. And again, the French Vexus group did the cluster analysis. The cluster 1 is consolidation with the GGOs, nodules, which evokes pulmonary infection or organized pneumonia as a differential. The other cluster is where there is atelectasis, bronchiectasis, and effusions. And the third one is mediastinal adenopathy, bilateral effusion, wherein it sometimes looks like heart failure. This is from the French Vexus group. Thrombotic manifestations are dominantly venous thrombosis. Arterial thrombosis have not been reported, and it occurs early in the course of disease. Our patient also had venous thrombosis. Coagulation, cascade activation, and localized vasculitis are the ones which have been proposed as a mechanism. And out of the antiphospholipid antibodies, chiefly lupus anticoagulant is the one which has been reported. There are high inflammatory markers, high D-dimer levels, and factor VIII levels which have been reported in these patients. The dominant hematological manifestations are cytopenias, MDS, and there can be MGUS and MDS co-occurrence also, and monoclonal B-cell lymphocytosis. The marrow shows ME ratio of 7:1. But the residents must always remember that there can always be other causes of vacuoles. These are alcohol intoxication, copper deficiency, zinc toxicity, and various myeloid neoplasias. So don't be in a tearing hurry if you see this on bone marrow report. These are the ones the vacuoles which were seen in our patient. This is image courtesy our professor of hematology, Dr. Rinan Das, and it's there in the upcoming textbook where the chapter has been written along with Peter Grayson. You would have seen this book is about to be unveiled. The other manifestation can be in the form of extraocular swelling or conjunctival swellings. These can, these kind of manifestation I've seen with venous granulomatosis, lateral rectus, extraocular muscle involvement, but this can very well occur with Vexus also. So besides GPA, you should consider this also amongst your differential diagnosis. So how do we diagnose? You sequence them. How do we treat? As I've already alluded to, they respond to high doses of corticosteroids. They are generally refractory to other immunosuppressants. And one thing which is showing promise is a jacanib, ruxolitinib, which is showing good response. The other thing, a word of caution is wherever anakinra is available, there have been reports of delayed onset skin hypersensitivity in these patients. Prognosis is not very good, high mortality rates, and these are dependent upon the types of mutations which these patients have, and median survival is generally 10 years. So coming on to the second condition, DADA2, when do we suspect? If there is early onset PAN, if there is a PAN which recurrent strokes, if there is a PAN which is familial, if there is a PAN kind of a phenotype with cytopenias, or if there is a PAN which has a phenotype of immunodeficiency, because generally CNS involvement in classical polyarteritis nodosa is not there. So these things are there, and or if from North India, if the patient happens to be from Agarwal Jain community, think about DADA2. This must also be thought about if there is a PAN which has an extensive livedoid rash, not only involving the lower limbs, but also on the trunk and also on the upper limbs, Sneddon syndrome kind of presentation, or bone marrow failure syndrome, must consider DADA2 as one of the differentials. So this was our paper. All patients except one had systemic vasculitis, one infant had pure red cell neoplasia. Two first degree relatives who were asymptomatic, but both of them had skin vasculitis and had central retinal artery occlusion. So these can present, two of our patients had presented first to the ophthalmologists. So what our data suggested as compared to what was reported previously was that it can very well be seen late in the adulthood as compared to what was reported in the entire literature till that time. And we've seen the patient coming as late as the first patient that I saw was 48 years old. So this is no longer a disease only of the childhood. These patients can very well be seen well into the adulthood for the first time. Both strokes, ischemic, hemorrhagic, cerebral aneurysms, even posterior reversible encephalopathy syndrome, kind of a manifestation which is shown in this MR here. Abdominal imaging is a backbone. You have end organ changes or microaneurysms. We've seen organ infarcts, we've seen splenic infarcts, renal infarcts, mesenteric ischemia, we've seen organomegalies, but unlike the NIH group, we did not see any focal nodular hyperplasia, no hepatic infarcts, no portal hypertension. We've seen vascular aneurysm, even we've seen peripheral arterial narrowing of the larger arteries like ulnar artery also in these patients. This is a pancreatic microaneurysm and pancreatic infarct which was not reported. This is a very striking picture. We've seen the intercostal artery aneurysm and aneurysm practically all the abdominal vessels in one of the patients of DARA2. We've seen a lung hemorrhage also in one of the patients who initially was a childhood onset polyarteritis nodosa. We presented this as a recurrent polyarteritis in 2014, Iracon. That time we didn't know about DARA2. So there is a genotype-phenotype correlation. The ones which have lower enzyme levels develop more like bone marrow failure syndrome. Those who are relatively higher levels of the enzyme have more of a vasculitic manifestation. This paper was from my friend and collaborator Kui Lee. You can on histopathology have both vasculitis and vasculopathy. Diagnosis can be both molecular or enzymatic. They have their own pros and cons. How do we treat? These are the various genetic variants. I think in the interest of time, anti-TNFs are shown that once you start anti-TNF, this is umbrella again from the NIH, the strokes don't really recur. Hematopoietic stem cell transplantation is the treatment for hematological manifestations. This is our own experience. Practically, anti-TNF is the one which works. What we showed that not only the stroke, other manifestations also respond very beautifully once you start the patients on the anti-TNF. But word of caution, we are already seeing a relapsing disease and it can be a nightmare. So to conclude, I would wish to say that you need to have a very high index of suspicion to diagnose VEXAS and DARA2. The evidence of managing in VEXAS is still evolving. Anti-TNFs are effective in vasculitic manifestations of DARA2. And I would wish you to look up, this book is ready. This is the second edition of the textbook of vasculitis. I'll request all of you to get enough, if you could have interest in this book, I'll be more than happy to get the critique, to get the comments, and I hope you will like as you love the first edition of this book. Thank you very much for your patient hearing. I'll be very happy to answer any questions.
Yeah. Can I request audience to present their questions or comments, please?
I will request someone also
Yes.
to come on the stage with the permission of the chair.
Yes, yes.
Good morning, sir. I'm Avnish. Sir, I have two questions for you, sir. Why do you think in VEXAS there is role, steroid is having response, but why the steroid sparing agents are not working? And second one, sir.
I wish I knew the answer.
The second.
I don't think anybody knows the answer. The thing is, both VEXAS and DARA2, they respond to high doses of steroids. The moment you, basically the immunopathogenetic mechanism we are at the early stage of understanding those. Once we know them as beautifully as we know for rheumatoid arthritis, we'll shoot those pathways. Probably these are early days. That time will come, perhaps in our lifetime.
Sir, second question is, so you have published a beautiful series of 33 patients. As you said, only one was pure red cell aplasia, while the data outside is much more higher.
We need to collaborate with our hematologists. That's what I'm doing.
Publication bias on that.
We need to look from the other perspective. There is definitely a bias.
Yeah.
It's a data from a rheumatologist, and I've been pressing our hematology colleagues to start looking at that. They are doing it. Once we have a good enough data, we'll come back with that data also.
Again, sir,
But that's seen more in children.
Again, sir, why TNFI is not working in PRC, pure red cell aplasia, but working in strokes and
Again,
other?
I don't know.
Like this. Thank you, sir. Thank you.
Anand Malviya from Delhi. Aman, thank you for excellent exposition of the latest advances in the field of diseases that we in olden days didn't even have a clue. What we kept on diagnosing, polyarthritis nodosa and Ashok is there. We published all those things. Probably many of them were Dada. My question, however, relates to Vexus. Recently there was a paper, you must be, of course, aware of that. For persons who are more general rheumatologists, can we have clusters for understanding that this cluster, for example, relapsing polychondritis cluster.
Yes.
Think about Dada. Vexus as one of the possibility. Similarly, there was a paper, they have 3 or 4 different clusters, so that it makes it easy. Can you, because you went too fast for a
I'm sorry.
senile brain like
my
mine,
but slowly.
I will like, and much of the audience may also be benefited if I can have the cluster of Vexus. Thank you.
Yes, I think that's masterly question from the master himself. I did show the clusters. I think what in the interest of the audience, I'll share those. That's a very important thing, what Sarah said. The French group has already made those clusters for the clinical manifestations and also for the pulmonary manifestations. There are 3 different clusters. One has a good prognosis. The other one second one has a very poor prognosis. And I think it will be very important for us at least to look at that both from RP perspective and from the Vexus perspective. Sir, it was there, but because of the formatting it got
You can show
changed
the
because I
slide.
made it on the Mac.
We can show the slide.
There was blurring because of I made it on Mac. It's not coming up very well. So what I do is I'll take a snapshot, share it on the IRA group immediately after my talk. Absolutely.
Thank you, sir, for the wonderful lecture. This is for Dr. Mondal. For routine follow-up of Takayasu in children to assess the vascular activity, what modality of imaging do you usually use?
For the year.
For follow-up.
For follow-up.
To assess the vascular activity.
For follow-up.
Like CRP, SR, they are just very indefinite markers. So what routinely do you use? Which modality of imaging in childhood for Takayasu?
In between these two, either MR angiogram or CT angiogram, but better is MR angiogram because in a childhood we do not want to expose them to radiation, and in a CT angiogram it almost take 14 to 17 millisievert, which is quite high. And if there is involvement of the common carotid or subclavian which are approachable by the USG, in a good hand, USG can be the best option for monitoring.
Okay. Do you do this imaging yearly for assessing the vascular status, or?
No, we do not perform it per yearly. The current recommendation is based on the clinical judgment. We can image the patient on 3 or 6 monthly interval, but we usually do it on on-demand basis.
Thank you.
Aman sir, very good presentation. This is regarding flare of Dada 2. Interesting story. You have seen 2 patients of mine and then diagnosed Dada 2. It started with the interesting story of I have presented a CME in periphery Dhar, and orthopedician told me, sir, 10 saal se, for 10 years my sister is suffering from this pan. So that day story started. She had aneurysm 10 years back, and then recurrent ulcers and neuropathy and all. Then I started with PAN, given cyclophosphamide, she went in remission. She later became pregnant, her daughter is good. Then her younger sister again had same symptom.
Of course.
Yes, and then came the story. Then I thought of I sent to you, and then you diagnosed Dada to both sisters. Yes.
I remember.
One sister was started on a TNF blocker, she is under remission. But other sister, she was on azathioprine and steroids.
Please ask your doubt. We are running short of time. Please ask your doubt. Yeah.
Both should be on anti-DNFs because this general story is there can be 5 to 6 years of interval in between before he hits, and hits very hard. I had a patient who had a stroke, multiple times he just had ataxic hemiparesis, then eventually ended up having dense hemiplegia. So treat both of them with anti-TNF.
My two questions. One is,
can we be short, sir?
on anti-TNF, but she has accelerated hypertension with adalimumab, 240/140. So what should I do now? Should I switch out to other TNF
We
blocker?
discuss the management one-to-one.
Okay.
Okay. That's a very important.
And why?
We need to look for also secondary hypertension and continue the anti-TNF. We cannot afford to stop anti-TNF while manage the hypertension the best way we can. That's point number one. Number two, the last caution is if a pan is not responding to cyclophosphamide, think about DADA2.
And so why
can
for 10
we-
years she was not having any aggression because you said relapse is severe?
Yeah. Sir, we are running short of time. Yeah. Only one last question.
My question is to Dr. Mondal, sir. I'm Dr. Prachi Patil. Sir, in Takayasu patients, what are the general indications for referring it to for the surgical intervention? And as a rheumatologist, what perioperative care we should take? And the third question is, how many times you repeat the imaging to assess the disease activity or the therapeutic?
As I have said, I am giving the last answer first. That is the recommendation is to repeat the image at least 3 or 6 month interval. But this is based on your decision. According to the clinical status of the patient, if you suspect there is new arterial involvement or a new pituitary involvement, then you can repeat the image earlier, or if it is not, you can delay it. Because in most of the imaging modalities which we currently have are either costly or have some radiation hazard for CT, MR and for the PET CT. USG, it is available, you can repeat it, there is no problem. There is but it cannot detect properly the descending thoracic aorta or the arch of aorta or the ascending aorta. This part cannot be imaged properly unless you do a transesophageal echocardiography. So for you can keep it to 3 to 6 month interval for the repetition of the images. And there are the indications for surgery when it is not responding to medical. There are some indications you can clearly see in the test group. When it is not responding to medical management, there is severe claudication, involvement of the cardiac involvement. Then you can perform some stenosis, or there is critical stenosis which is not medically managed. And thirdly, before preoperative management, one thing you should check, that is the central arterial pressure, because in most of the cases, in patients who have bilateral subclavian involvement or abdominal aorta involvement, we cannot check the artery BP properly. Only in that case, a catheter-based angiogram is mandatory to check the central arterial pressure before performing the surgery. This is the difference.
Thank you, sir.
Thank you, Dr. Aman and Dr. Mondal. It was an excellent session, both the sessions.
Thank you very much.
So now we move on to the we move on to the next speaker, Dr. Anup. Is he there? Yeah.
Please put on the slide.
Challenges of seronegative APS posing as medium vessel vasculitis. Dr. Anup, please.
Good morning. At the outset, I would like to thank the organizers of this fantastic meeting for this opportunity. I offered this particular topic which is very challenging to field and medium vessel vasculitis.
Probably DADA now.
Hypophosphate syndrome. APS is defined as vascular thrombosis and a pregnancy morbidity occurring in the setting of persistently positive antiphospholipid antibodies. Coming to the criteria for the diagnosis and classification, there are lab criteria, there is thrombotic criteria, and there is pregnancy-related morbidity. In the lab criteria, there is lupus anticoagulant and anticoagulant antibody, IgG and IgM, and anti-beta-2 glycoprotein, IgG and IgM. And coming to the thrombotic, this one, arterial thrombosis confirmed by imaging, venous thrombosis confirmed by imaging, and small vessel thrombosis confirmed by imaging. And pregnancy morbidity, there is unexplained miscarriage more than 10 weeks of gestation with premature birth before 34th week of gestation and more than 3 unexplained consecutive miscarriages less than 10 weeks of gestation. There is always some pitfalls in classification criteria, and the potential pitfall in applying this classification criteria to make the diagnosis of APS is that a significant percentage of the patients with APS will not be diagnosed, and failure of anticoagulation will lead to lots of adverse consequences and mortalities and morbidities. Coming to the various conditions which is associated with antiphospholipid syndrome, so majority of them are autoimmune systemic autoimmune related diseases and just like lupus, IgE, rheumatoid, Sjogren's, Janssen arthritis, MCTD, Behçet's, polyarthritis nodosa. And this one, coming to that, another important this is malignancy associated conditions like solid tumors, leukemia, lymphoproliferative diseases, Hodgkin disease, multiple myeloma, and hematological diseases like myelofibrosis, von Willebrand disease. The infectious disease is another important category, which is mainly syphilis, leishmaniasis, tuberculosis, Lyme disease, HIV. And neurological diseases like myasthenia gravis, multiple sclerosis, and migraine sometimes are very important. And medications like hydralazine, propanamide, imidine, and clozapine. In clinical practice, according to this classification criteria, it is possible to identify following three clinical conditions. And patients with unusual clinical manifestation of APS associated with the positivity of APL from antibodies, that is, a thrombotic events in typical sites such as deep vein thrombosis of the lower limbs, pulmonary embolism, myocardial infarction, and stroke or typical pregnancy disorders. And another condition, patients with unusual clinical presentation of typical manifestation of APS associated with positivity of antiphospholipid syndrome, antiphospholipid antibodies. And thrombotic events in atypical districts, particularly liver, renal, adrenal, mesenteric vessels, and CNS sinuses, and with unclear presentation and difficult diagnosis. And another class is patients with non-criteria clinical manifestations of APS associated with positivity of antiphospholipid syndrome. That is non-thrombotic pulmonary or cardiac involvement, ocular, non-neurological, osteoarticular, and hematological manifestations. And this is something which is Dr. Kirtan has presented in latest ACR a few days before. They have actually proposed a new draft for ACR regular antiphospholipid syndrome criteria. Now, what is predominantly new is that there is an entry criterion like more than one documented clinical criteria and one positive APL test, and clinical domains like venous thromboembolism, arterial thrombosis, microvascular environment, obstetric and cardiac wall. So what is microvascular involvement? Microvascular involvement is divided into two. There is microvascular involvement suspected and established. Suspected, they have conditions like livedoid rhythmosa, livedoid vasculopathy, APL nephropathy, and pulmonary hemorrhage. And established like livedoid vasculopathy, APL nephropathy, pulmonary hemorrhage, all those things. And laboratory criteria, they have got lupus anticoagulant positivity, one-time and persistent positivity, and anti-cardiolipin, anti-beta-2 positivity. That one also they divided into two, both depending upon the IgM and IgG. And the IgG also, it has, depending upon the titer, they have divided into moderate positivity, high positivity for both antibodies. Coming to this, they have actually this one venous thromboembolic risk stratification has been done, and there is major VT risk factors and minor VT risk factors, and along with that, they have actually did a stratification for a CVD risk profile also. So those people who has gotten high CVD risk factors and a moderate CVD risk factors. Higher CVD risk factors like severe arterial hypertension, long-standing diabetes, hyperlipidemia, CKD, and moderate CVD risk factors like non-severe arterial hypertension, diabetes, moderate hyperlipidemia, current smoking, and obesity. So coming to this, the risk stratification of microvascular events by traditional thrombosis risk factors, they have actually well-defined microvascular domains items and redefined pregnancy morbidity definitions, and the addition of cardiac valve disease and thrombocytopenia. So another they have included a novel laboratory features also, quantifying single, double, and triple APL positivity, and separating ACL and anti-beta-2 GP1, IgG, and IgM isotypes, and defining two levels for ACL and anti-beta-2 GP1 positivity that we interpret as a clinically relevant in most investigators. So new criteria, what are the major strengths? There is stratification of macrovascular events, well-defined microvascular domains items, redefining pregnancy morbidity, addition of cardiovascular valvular heart diseases, addition of thrombocytopenia, and separating IgM and IgA subtypes, and defining 2 levels of antibody positivity. So coming to clinical features, everyone knows arterial and venous thrombosis are usually present with pregnancy morbidities, and CNS they have got cognitive dysfunction, seizures, transient ischemic attack, transient myelopathy, migraine, multiple sclerosis like presentations, chorea and psychosis, and severe they have got heart valve diseases, thickening, vegetation, stenosis. And skin, they have varied presentations like reticularis, legansis, gangrene, nail bed insults, pseudovasculitis, vasculopathy, and angioedema. Hematologically, they can present as DCT positive autoimmune hemolytic anemia, thrombocytopenia, and HUS, DTP, and AVM. APS nephropathy and pulmonary, they can present with pulmonary embolism, diffuse alveolar hemorrhage, and pulmonary arterial hypertension. If you look at 1,000 patients, majority of them they will be present with DVT, 32%, and thrombocytopenia 20%, livedo reticularis 20%, stroke with 13%, and superficial thrombophlebitis, pulmonary embolism, fetal loss. Coming to catastrophic APS, 3 or more organs are involved, and definition is criteria, and less than 1 week duration, demonstration of thrombosis, and demonstration of APL antibodies 6 weeks apart, and microvascular thrombosis evidence, and the patient should have a fulminant course for the disease. Coming to the laboratory testing in APS, IgM and IgG anticoagulant antibody by ELISA, IgM beta 2 glycoprotein by ELISA, and mucus anticoagulant both screening and confirmatory test DRVBT, and confirmatory test after and repeat the test after 12 weeks. So laboratory testing in APS, why we want to repeat the test? The transient elevation of antibody can occur due to drugs or varied other causes like infections. And other tests includes IgA anticoagulant antibody and IgA beta 2 glycoprotein antibody are not recommended because of the post-amplification. And triple APL positivity has the highest risk of recurrent thromboembolism. Coming to the seronegative APS. The first definition of seronegative APS was in 2003 by Hughes and Kamasta, who described the patients with clinical manifestations of highly suggestive of APS in the absence of laboratory criteria such as lupus anticoagulant, anticoagulant, and beta-2 GP1 antibodies. And seronegative APS is usually diagnosed with exclusion, including protein C, protein S, and antithrombin deficiency, and which is suspected in patients with typical clinical history suggestive of APS with persistent negativity of APL antibodies on 2 occasions when other causes of thrombosis are excluded. Patients' personal history should be carefully investigated to exclude previous positivity for any antiphospholipid antibodies. And IgA, the antibodies to cardiolipin and anti-beta 2 glycoprotein GP1A. There was also a retrospective case control study of 56 patients with an isolated anti-beta 2 IgA found that patients with this marker had a significantly more thromboembolic events than the controls. And elevated anti-beta 2 GP1 IgA was reported to be associated with an increase of risk of thromboembolic disease in the patients, especially in patients with LV. And antiphosphatidylserine antibody assay in arterial thrombosis, antiphosphatidylserine antibodies were reported to be better correlated with APS than ACL antibodies. And another important antibody like antiphosphatidylserine prothrombic complex, IgG antibodies against the phosphatidylserine prothrombic complex were reported to be highly prevalent in APS patients compared to the patients' other diseases with an odds ratio of 12.8. And another important anti-domain antibody is anti-domain 1 anti-beta 2 glycoprotein antibody. This antibody assay identifies immunoglobulin G antibodies against a specific epitope of beta 2 GP1. And a recent multicentric studies of 442 patients who tested positive for anti-beta 2 GP1 antibodies reported that detection of a specific anti-domain 1 IgG antibody was strongly associated with thrombosis and oxidative complications, and then anti-beta 2 GP1 antibodies detected using the standard antibody anti-beta 2 glycoprotein 1 assays. What are the possible explanations for the existence of the seronegative APS? Either the diagnosis is wrong, previously a positive antiphospholipid test become negative, sometimes maybe naturally. Most likely the current range of tests are inadequate. It may depend either on the limits of the traditional techniques approaches we are using or on the existence of the different antigenic targets. So these are the extra criteria antibodies in seronegative antiphospholipid syndrome and its predominant clinical manifestations. Anti-prothrombin phosphatidylserine antibodies, which is clinically related with thrombotic risk. Anti-annexin 5 antibodies, anti-annexin A5 resistance, antibodies to vimentin and annexin A5 and vimentin and cadolactin complex, phosphatidylethylamine, phosphatidic acid, phosphatidylserine, phosphatidylinositol, and IgA ACL and IgA beta-2 GLP-1 antibodies. Among this, most important one which is studied is anti-phosphatidylserine plus prothrombin complex and anti-phosphatidylserine antibody. Coming to the novel approaches to identify...
Anup, can you finish fast? There's a plenary session going on and we have to finish fast. We are overstepping the time.
Yeah, there are some proteomic approaches which can identify vimentin and anti-cadolactin, and new detecting method, antiphospholipid immunostaining on thin layer chromatography plates. And this is a non-quantitative technique that identifies the reactivity of the serum APL with phospholipid molecules. And limitation of this method could be relatively low sensitivity, since only 68% of this true APLs derive a positive of the coming to the extra criteria, antibodies, manifestation of antibodies, antiphospholipid syndrome. There are various involvement, varied manifestations of different organs, nervous system, skin, heart and blood, kidneys, which are discussed earlier.
I think that's
and
done.
These are the case control studies, case series predominantly, which looked into the positivity for extra criteria antibodies in each study of seronegativity. I mean, most of the antibody studies was actually antiphospholipid ethanolamine, antiphospholipid APS PT complex, and anti-annexin 5. Out of this, this one.
Short, please.
Patients. Coming to the APS antibodies and APS in systemic vasculitis, there are varied systemic manifestations from different organ systems. And coming to the vasculitis and antibodies, APL antibodies have been reported in conjunction with all systemic vasculitis. And the case reports of APS occurring in the context of all subtypes of AAV as in APS patients with ankylosing vasculitis present with pulmonary capillaritis and diffuse alveolar hemorrhage. So this is the only randomized controlled trial which has got eugenous diameter. It was a weak clot study.
Can we, Dr.
180 GPA patients, incidence of venous thromboembolic events to be 7 per 100. This rate was 20-fold higher than the general population and 7-fold higher than the observed in SLE patients. And venous thromboembolic events were temporarily associated with periods of active diseases. And there is SPAN also associated with this particular seronegative antibodies, this one. And what are the important points which we can ponder? Antiphospholipid antibodies likely coexist with the vasculitis and connective tissue diseases such as lupus, and differentiating between inflammatory and thrombotic causes of vascular damage remains challenging. And antiphospholipid antibodies are increased in certain primary systemic vasculitis. However, a causative association of APL antibodies with thrombosis in these patients has not been proven. Most of the time, on repeat testing of antiphospholipid antibodies may be negative. So long-standing anticoagulation is usually not recommended, and routine testing for APL antibodies in primary vasculitis is not recommended. And significance of APL in primary vasculitis is less certain and may represent the result of an endothelial cell damage or an epiphenomenon. And what is the role of new ACR criteria, which will be more helpful in addressing non-criteria manifestations of APLs?
Thank you, Dr. Anup. Dr. Rajeshwari ma'am will just give an overview and a few practice tips. You can sit. I don't think we have time for this. It was very good actually.
Thank you.
Can you tell me I'm audible?
Yes, ma'am.
For the remaining audience or questions here, can you just switch over to my slides fast? So the topic given to us actually today was seronegative APLA presenting as medium vessel vasculitis. But it's very hard to find references to that, and hence this long lecture on non-criteria manifestations as well, and those who are apparently seronegative. So I will just present some slides which we get to see in practical situations and clinical situations. The differences between seronegative APLA, as it's presumed to be, and the medium vessel vasculitis. The first two pictures above and below show the livedoid vasculopathy, which is occurring in APLA, which may be positive or negative for antibodies. This is the acute stage. The second one shows the scarred stage, which we call as livedoid vasculopathy or atrophic large, because it's white and star-shaped and has a lacy pattern. It's bilateral and symmetrical, which occurs over both the lower limbs, and it can mimic the cutaneous ulcers of cutaneous pan, or which can be a cutaneous manifestation of classical systemic pan. The problem arises in the management of these two. One needs the livedoid or the atrophic large does not need immunosuppressive therapy. It can be managed just with aspirin, clopidogrel, and if it warrants, oral anticoagulants as and when necessary. The second one, if it's going to be secondary to vasculitis, which can mimic this, then immunosuppressives and steroids are the must. So don't go around wasting your time managing these two. So don't get worried. You should know the clinical situation as to how APLA can mimic medium vessel vasculitis. And the third one is, you can see the beautiful spider pattern or the lacy pattern of livedoid reticularis, which can occur both in pan, medium vessel vasculitis, as well as in APLA. So that can be primarily due to thrombophlebitis or secondary to occlusion. So depending upon the APLA positivity, or even if it's APLA negative, or if you're suspecting just thrombotic episodes along with this and with the presentation of cutaneous infarcts with no systemic manifestation, think of APLA as well. The first picture is a very classical picture of leg ulcers occurring in APLA. We had a patient last week. She had, as he said, about the neurological manifestations, cardiovascular and cutaneous manifestations, which can be atypical, but she turned out to be APLA positive. Even in APLA negative patients, these ulcers are very classical with a scarring pattern like this, almost like a keloid. The peculiarity is they occur over the bony surfaces, over the shin, over the bones, whereas the cutaneous pan ulcers will be situated laterally in the arterial territory. That's very classical. You know, the venous ulcers occur over the medial aspect of the leg. And you can see the cutaneous, the leg ulcers of pan. You see the edges, how they will be, and the differential diagnosis is totally different. They can mimic pyoderma granulosa also. And obviously the treatment is different. And finally you can see the gangrene, which can occur in both. You can get occlusion of the vessels, and those are the cutaneous infarcts of pan. You can get the same infarcts in APLA also, which Anup is already mentioned. Why this is important is because the treatment varies, and here in the legend itself shows, and the arrows are showing the cortical infarcts which can occur, especially in catastrophic APS, which is very, very classical, showing the rim pattern, and those are the renal infarcts of pan, which occur close to the medulla, and the aneurysms also are in the intrarenal area. Okay. And this is the ocular manifestation. Again, you can see the thrombosis in APLA, and this is fundus fluoris, and you can see the ink blotches like that, the splashing of the exudation from the veins of blood. And there you can see the central retinal vein and ophthalmic artery occlusion with a very pale disc. CRAO also can occur. This is a classical picture of retinal vasculitis in lupus. You can see the perivascular sheathing and the cotton wool spots, which are nothing but ischemic vasculopathy, ischemic neuropathy. And these are the multiple cerebral infarcts of APS. They are all very asymmetrically distributed, whereas that's a hyperretinal infarct of APLA, again, which can correspond to the territory showing an MCA occlusion on the left side. Again, these are the vasculitic infarcts are very fluffy. They pick up on flare because they are highly vascular and inflammatory, and they are found very close to the gyrus, gyral margins, where the blood vessels enter into the cerebral cortex. So you can see the beautiful distribution over there, and there you can see the primary CNS vasculitis, which can be a medium or a small vessel vasculitis. And there you can see again those infarcts, they can mimic anything. The primary CNS vasculitis infarcts, it's a brain biopsy, which is going to be the standard investigation. You can have the three varieties: the fibrillar necrosis variety, which is a medium vessel, the lymphocytic, or the granulomatous variety.
Madam, can the...
All these three are
Rajeshri
Thank you very much. And why it's important is, concluding Anup's and my slides, is the treatment is totally different. Don't go around wasting your time treating them as vasculitis where it might turn out to be a vasculopathy. We do not have adequate investigations. There may be many more APLA antibodies, and we have to think of the non-criteria antibodies which we may clinically call as a seronegative APLA, and this is just for your information. Thank you for your kind listening and patient attention. This program started late, since that's why we don't have enough time.
Ma'am, I'm from Kerala. My name is Vishnu. I have a patient who is having non-classical manifestations only because she is 60 years old. She is having vasculitis and autoimmune hemolytic anemia. So as we know that we should treat this with